Donor selection. This is step one in reducing the risk for transfusion. Transfusion is never risk-free. There are always risks associated with it. As blood bankers, our job is to minimize those risks. And the way we do that to start with is to make sure that we have basically healthy donors who are going to be at low risk of transmitting any kind of diseases. There are two types of collection. There's autologous and homologous. Auto means self, so an autologous is for a self, is blood that you give to use yourself. Homologous is blood that you give for other people to use. Now, there's two ways that we can collect units. We can either collect, basically take a bag of blood, hook it up to your arm, fill it, and that's collection number one. The other way we can collect is by a process called apheresis. And this is where we would remove the blood from your body, pull out the components we want, and give everything back to you. We'll talk more about this when we are discussing component preparation. So, autologous donation was very popular during the height of the AIDS epidemic when they didn't quite know what was going on. A lot of people were terrified to get units of blood. So in an autologous donation, what you do is the physician writes an order and gives the patient permission to donate. The biggest thing to remember is that autologous donors do not have to meet all of the homologous criteria. They do not have to meet the health requirements. They do not have to meet the hemoglobin requirements. And they do not have to meet the viral testing requirements. So some of these people were not in the best shape to be donating anyway. We do not have to test their units for viruses. As a matter of fact, if you collect it, store it, and transfuse it at the same place, you don't have to test at all. Now, if you collect it one place and transfuse it elsewhere, you do have to perform some limited viral testing on each unit collected in the first unit collected in any 30-day period. And that's one place where we differ because homologous donors can't give every 30 days. They have to be 56 days before they give again. So there were a lot of different things that autologous donors can do that homologous donors can't. So once we have collected this unit, we have to label it to death that says autologous use, for use this patient only, and it has to have full patient information on it so that you know that it is going to exactly the person who gave it. If the unit is not used by that person, it cannot be released to the general donor population. It must be destroyed. While that unit is in the blood bank, it must be kept in a physically separate location from the homologous units to make sure that it is not accidentally picked up and given as a homologous unit. It's actually quite a pain to have to deal with autologous units to make sure that you're storing it properly away from everything else. A lot of places don't even keep them. So autologous units are less and less used. Now, I'm not exactly sure how much less. You'd have to look that one up. There are some other things we can do as far as autologous collection. These aren't strictly blood bank driven because most of the time, as long as they occur within the operating suite or the PACU, we don't really have to deal with them at all. So as long as everything's done at the patient bedside, we don't really have much to do with it at all. The first is acute normovolemic hemodilution. This is where you pull out a unit at the beginning of surgery and you hold on to that during the surgery. And while you are removing that unit, you actually are infusing colloid or crystalloid solution so that you keep their blood volume up and you keep their blood pressure up. And then you can go ahead and transfuse that back later during surgery if there is a need for it. This other one is intraoperative collection, also known as shed blood. Essentially, here what you do is you suction out the blood from the surgical site. It is collected into a container. It is taken over and washed to remove any yucky stuff on it, and then returned to the patient through a microaggregate filter to make sure that no bone shards or other detritus that might be in there is transfused back into the patient. Postoperative blood salvage is essentially the same thing, except that instead of suction from an open site, it is hooked up to a sterile drain, and then you take the blood after it's come out and you flip it over and you transfuse it right back in again through a microaggregate filter. Directed donors, these are a homologous donation that is given for a specific individual. If you talk to really, really old people, they'll tell you how, well, when my mom had her surgery, the blood bank just said we had to get 3 people come in and donate, and then we didn't have to pay for it. Well, you technically don't pay for a unit of blood, you pay for the processing on the unit of blood. And at one time they did say if you can get people to replenish the blood supply, then we won't charge you for that unit. That has not happened in a very, very long time. The other thing for directed donors was kind of I want to know where my blood's coming from, and I don't want it just some random stranger to be giving me blood. So directed donors were kind of set up, and what this is somebody goes in and they fill out a whole bunch of paperwork that says, I am donating blood for this specific person. Then they come in, they have to meet all of the regular criteria for a donor. Every other criteria that a regular homologous donor has to meet, they have to meet as well. Then the donor is drawn, the unit is collected and processed, and it is labeled the same way any other unit is, but it has some additional paperwork and additional labeling as to who that is particularly for. One of the problems that they kind of ran into with directed donation, let's say your mom calls and says, I need you to give blood for Aunt Muriel, but you maybe are engaging in some unsafe practices and you don't want your mom and Aunt Muriel to know just that your lifestyle is not necessarily a safe one. So you can't really say no, so you go in and you give the unit anyway. Well, those of you who've given blood know that there's actually a step in there now where you can mark a box that says, don't use my unit. That's why that is in there, is because that way if you are sort of encouraged in some way by family or employers or anybody else, you can go in and look like you gave a unit and mark it as unsafe, and that way your unit is not going to go to somebody. Now, once the donor is not needing it anymore, there are 2 options. Most of the time, the people select the option that just says, well, then just go ahead and give it to somebody else. Since the unit meets all the criteria, you can go ahead and use it for someone else. Although there is the option in there that if they don't give it to the intended recipient, it can be destroyed. But directed donors are another thing we don't really like to deal with in the hospital blood banks, because it's kind of a pain to try and make sure everything, keep track of everything, and they have to be put in a separate space and everything else. So a lot of places don't mess with directed donors either. Okay, so now we come to the bulk of donation, and that is the homologous donors. The first thing is that all donors must be volunteer. They cannot be paid for blood. So if you hear of somebody who's getting paid for their donations, that is probably from a reagent or pharmaceutical manufacturer who is buying plasma. That you can purchase. People sell that. It is then collected and taken to a variety of factories where it is turned into pharmaceutical or reagents. It is not used for transfusing to patients. It is illegal to pay donors. In fact, as I remember at one time, there was kind of a fuss about, is it legal? You know, you're giving them T-shirts and gift cards and things like that for blood drives. You know, is that legal? And well, luckily they said that that's okay, because you know there's those of us who require those donor shirts to keep our wardrobe up to date. Donor has to be provided with educational materials, whether you know it or not. Every time they hand you the clipboard with all the questions to fill out on it, somewhere either on the back or on an additional paper behind it, or you can ask for it. I'm not sure where it is these days anymore, but is a flyer that tells you the risks of giving blood and what could happen and what won't happen, and explains the whole process to you. And you have to be provided by law with that material. The donor has to provide valid identification. You have to sign an informed consent that says, yes, I read the educational materials and I meet the criteria and I can give blood. You have to complete a history questionnaire and a limited physical exam. So donor identification, generally they require a photo ID, such as a passport or a driver's license. Some places a school ID or a work ID will work. But essentially, and then they have to collect demographic information, name, address, telephone number. They need to be able to get a hold of you in case they have further questions or something unexpected comes up with your unit. They ask your gender. This is self-identified and self-reported. It doesn't really matter that much. There are some things that we don't use female blood for. And then they also check your age or your date of birth. They have to give you time to review the educational materials, and then they have you sign an informed consent to donate. And they also are going to go back and check your identification against the donor registries of people who've come through to make sure that you are not on a deferral list. Then we come to the great big donor questionnaire. And AABB, in case you don't remember, is the American Association for Blood Banking. And they've developed this nice, big, huge, long history questionnaire. They also have a more abbreviated form. And this questionnaire serves two purposes. The first is to protect the donor. We want to make sure you're healthy enough to give blood, and that giving a unit of blood is not going to be a bad thing for you. We also do it to protect the recipient. We're going to make sure that the donor doesn't have any problems. Certain medications can't be given to people. You want to make sure that you're not going to expose them to disease. Certain vaccinations prove an increased risk, and we want to make sure that your lifestyle is not high risk, so that there is a lower risk of transmitting anything through the unit of blood. Everything falls on the medical director's shoulders. The American Red Cross, Mississippi Valley Regional Blood Center, and all the other various blood donor centers throughout the country each have a medical director. And it is up to the medical director to establish criteria for donor deferral. And usually that comes in the form of a list that you check it off, and it's fairly straightforward. Individual cases can be looked at by the medical director to evaluate the circumstances on a more individual basis. The only example of this I can think of, we had a patient who was negative for a relatively uncommon antigen and had a minor procedure that would have deferred him, and the medical director said, no, that's okay, he can go ahead and give. We need the blood that is negative for this particular antigen. So while technically he did have a surgical procedure, it was minor and it isn't impose any risk on the recipient. So he went ahead and allowed the override. There are three types of deferral. The first is temporary, and this just means that for a limited period of time, you can't give blood just until some situation has passed. You've either been exposed to something or you've taken something, but for some reason, for a specified period of time, you can't give blood. The third one is permanent. That means you can never donate again, ever, ever, never. The middle one is indefinite. And indefinite just means that the way things stand right now, no, you can't give blood. But times can change, testing can change, and eventually in the future, you may be able to give blood again. Okay. Now, donor requirements are sometimes fluid and they get reevaluated periodically. These are current as of March of 2020, but new outbreaks may require additional questioning or testing. West Nile virus and the Zika virus both created all kinds of problems for the blood centers when they first came out, and many people were deferred until something came up where we could then test for it. But we had to reevaluate our medical questionnaire and add some questions to it because of those outbreaks. Okay, I've I've spelled out the entire questionnaire and what gets deferred for what. I'm not necessarily going to go through every single one of these. The information is all here. Feel free to read it. Just going to try and hit some of the more important points. Obviously, you have to be feeling well today. You shouldn't be giving blood if you don't feel good. Antibiotics, basically any medication you're taking for an infection, you shouldn't be giving blood if you have an infection. So most of the time, we're going to defer you just till you complete the antibiotics. The medication guidelines are constantly changing. The FDA maintains a list on its website. Medical directors may modify this list and add other medications to it. So basically, you're just going to check and see what the medication list tells you. There's a current list in your book that has that, or again, you could go to the FDA website and check it out. Aspirin, we don't defer for that, but we do want to make sure that that is not the primary source of platelets for a patient, because aspirin is going to inactivate the platelets. Pregnancy, basically, you shouldn't give blood, or if you are currently pregnant or have been pregnant anytime in the last 6 weeks or so. If you had a miscarriage or an abortion in the first or second trimester, once you're feeling better, you should be able to go ahead and give if you wanted to. These are the number of days between donations. Whole blood is 56 days, that's 8 weeks. A double red or an apheresis 2-RBC is where they take out just the red cells, give you your plasma back, but they draw twice as many red cells off, and so you have to wait 16 weeks before you can give. Your apheresis leukocytes or platelets you can give every 48 hours, but there are maximum numbers of times you can donate in a week, a month, and a year. And apheresis plasma you can't give any more often than every 4 weeks. Vaccination, here's a list of which vaccinations have to be deferred for what period of time. It basically has to do with the type of vaccination. Rubiola, mumps, polio, typhoid, and yellow fever are live virus. Smallpox, you have to wait till the scab falls off. And if you have anyone who is living in the house, if you are around and in close contact with someone who has smallpox vaccine, you also cannot give until 21 days later. The most common length of deferral time is 12 months. So if you don't know, guess 12 months. That's always a good guess. All right. So anytime you've had exposure to blood, such as a transfusion, a transplant, a graft, an accidental needle stick, Sexual contact with anyone who might be at increased risk of having a transmittable disease such as hepatitis or HIV. All of those are a 12-month deferral after the last contact. If you have had a tattoo or a body piercing, that's also 12 months. Gonorrhea or syphilis, again, 12 months. If you have been in jail for more than 72 hours, 12 months. Okay. Hepatitis, having hepatitis, living with someone who had hepatitis, or having sexual contact with anyone who has had hepatitis, if you have been diagnosed with hepatitis, you should have a permanent deferral. If you have a positive surface antigen test, permanent deferral. Indefinite deferral if you have a positive core antibody or an NAT test for hepatitis B viral DNA. If you have been in contact with somebody who had hepatitis or tested positive, it's a 12-month deferral. Okay, travel outside of the U.S. is basically, depending on where you went, what they're looking at. So if you're looking for areas that are endemic to malaria, and again, you can look that up on the AABB or the FDA website and it will list them. Essentially, draw a line at the Tropic of Capricorn, the Tropic of Cancer, and everything right around the equator. That's essentially where you're going to start. Okay. So any place that is endemic for malaria, you should be deferred 12 months if you visited there. If you lived there for more than 5 years, they're going to defer you for 3 years. And if you had any symptoms or been diagnosed with malaria, it's going to be 3 years. Leishmania, this became a problem with Middle East, with troops being deployed to the Middle East. So 12 months after departing an area that is endemic for leishmania, and a lot of this is Northern Africa and Southeast Asia. Africa, areas that are endemic for HIV 1 group O, permanent deferral. For those who lived in the endemic areas after 1977, those who received transfusion in the endemic areas, and patients who have had sexual contact with anyone from an endemic area, they should also be deferred. The whole bovine encephalitis, Creutzfeldt-Jacobs disease in Europe became a massive mess for the donor population. What it has boiled down to at this point now is that if you received a blood transfusion in the United Kingdom or France after 1980, if any of your relatives has ever had Creutzfeldt-Jakob disease, or if you were a member of the U.S. military stationed in Europe for greater than 6 months after 1980, you should be deferred indefinitely. If you were in the United Kingdom for more than a 3-month period, or a series of periods that added up to 3 months between 1980 and 1996, you are going to be deferred. And this, quote, indefinite, end quote, deferral is very likely going to be a permanent. All right, this last set of questions is just kind of a general overall last minute, make sure that we've captured everything, make sure we've asked you everything, and we're going to ask you a couple things again just to make sure. If you ever had a positive HIV or AIDS test, you are indefinitely deferred. If you have ever taken IV illegal substances, you are indefinitely deferred. If you have ever been a prostitute, you're deferred for 12 months after the last incident. Anyone who has either used clotting factor concentrates or had sexual contact with someone who used clotting factor concentrates is also at an increased risk. Remember I told you that pharmaceutical companies can buy plasma. Well, that's what they use to purify out factor factor 8 and factor 9 for patients with hemophilia A and hemophilia B. Because so many different people's plasma is put into manufacturing these clotting factors, it puts the patients at an increased risk of disease transmission. If you've ever had Babesia or Chagas disease, you're going to be deferred. If you ever received a dura mater, which is the brain covering of the brain, if they've ever given you a transplant of dura mater, you are permanently deferred. If you ever received cells or tissues from animals, living tissues, you are permanently deferred. Things like porcine insulin, or just like heart valves or blood vessels or anything that is not living tissue, that's okay. But if you've received any kind of cells or tissues from animals, you are permanent deferral. Cancer, heart, lung disease, or bleeding conditions, these are an indefinite deferral, and depending on the exact condition, you can definitely, as long as you have recovered and you're doing well, can get permission to donate from the medical director of the blood center. Physical exam, you have to be between the ages of 16 and 65. There are a few states that have a minimum age of 17. Both Illinois and Missouri are 16. You have to be generally healthy in appearance. Your arm should be free of skin lesions. Basically, they're looking to make sure that your arms don't look like you've been using illicit IV drugs. Things like poison ivy or rashes of that sort are acceptable, but they should not be at the site of venipuncture. You should not be drawing through them. The minimum weight is 110 pounds. You can give blood if you're less than 110 pounds. They generally won't let you, simply because you're only allowed to draw a certain volume of blood off based on the patient's total blood volume. If there is a reason specifically that someone who weighs less than 100 pounds needs to give blood, again, we're looking here, unusual circumstances, rare donor, or some sort of compatibility issues that make them particularly necessary. You can recalculate the total amount of blood that is collected, but you also have to recalculate the amount of anticoagulant that's in there. Most of the time, they don't bother with it. Most of the time, they just say you have to weigh at least 110 pounds. You can't have a fever, so your temperature has to be less than or equal to 99.5 Fahrenheit or 37.5 centigrade. Your blood pressure needs to be less than 180 over 100, and your resting pulse rate should be between 50 and 100 beats per minute. When you go in, they're going to test your hemoglobin. I know they say they test your iron. They're not testing your iron. They're testing your hemoglobin. So they're testing your hemoglobin from a dermal puncture. The initial test is copper sulfate test. Basically, you have the blue solution that's sitting in the little tube that's sitting there is copper sulfate. There is one tube that is 1.053 specific gravity, and the other has a specific gravity of 1.055. If you're a girl, they put it in the 1.053. If you're a boy, they put it in the 1.055. If the drop sinks, you got enough blood, you move on. If it floats, that means you need some additional testing. And sometimes at the end of the day, everybody's floats, because as you add all that extra blood into there, it sort of changes the specific gravity of the solution. If it floats, you can do a specific testing, such as a spun hematocrit, or there are a lot of little point-of-care hemoglobinometers that they can use now. But this copper sulfate's super cheap, and it's good enough for determining whether or not you can donate or not. You have to validate that the patient has adequate levels for donation. Basic, just collecting a whole unit. The main one we're looking at is hemoglobin. Males have to have a hemoglobin greater than 13 with a crit greater than 39. Females have to have a hemoglobin of 12.5 with a crit of greater than 38. And regardless of gender, you have to have a crit of greater than 40 to be able to do a double red. Plus, you have to meet some size requirements. You have to be big enough to be able to collect the extra volume. With the advent of apheresis collection, we have to look at a couple of other things. If you're going to donate apheresis platelets and you have given in a relatively recent amount of time, you're going to have to check your platelet count and make sure it's better than 150. Leukocytes, you have to make sure that your white count is greater than 4,000. And for plasmapheresis, especially for those who are serial donors, this is people who give about every 4 weeks. They're going to watch your total protein and make sure that it remains over 6 grams per deciliter to make sure that you haven't given too much plasma.